Thanks everybody for coming today. An outline of my talk. So I'm going to talk about how I got involved in Recover, a bit about the Recover study design. Recover is still a very new study. We're actively collecting data, so we haven't done a lot of science yet. But I'm going to talk about a paper that was published that I was involved with, along with a lot of other investigators from Recover, about identifying long COVID and subtypes of long COVID. Talk a little bit about where we go from here with Recover, and then acknowledgements and discussion, hopefully. So how I got involved in Recover. So Citi gave me a very nice introduction with my titles. I will say, though, that I am quite junior for the Recover investigators. So most of the people who are leaders in Recover are assistant vice presidents of research for universities. There are deans and associate deans. So one of the interesting things about our site here at UAB is that Nathan Erdman and I are the MPIs. Until recently, Jeannie Barazzo was our contact PI, though she was not much involved in the day-to-day and has since gone on to be the head of NIAID. So that has been interesting. So to start with, just to remind you, so this is not a full timeline of what happened with COVID, but this is a timeline from my perspective. So, I take this with a grain of salt. And if you're interested, the CDC has a very good timeline. It's a lot more complete than what I'm going to talk about, and a lot less individually centered. So if you remember, December 12 and December 31 are sort of 2019 are when we started really thinking about COVID, right? So the WHO is informed on December 31st of 2019. And January and February of 2020 is when, we start getting the first documented case in the US. Things start moving really, really quickly, both in terms of the spread of the pandemic, as well as the science related to the pandemic, right? So within a couple weeks, honestly, SARS-CoV-2 virus is sequenced, and that viral sequence is shared with the WHO. And there are journal articles that are starting to come out essentially right away. So the science of COVID-19 is moving really fast along with the spread of the pandemic. So in March 2020, right, so up until the beginning of March, it sort of looked like things were potentially going to be bad outside of the US. And then suddenly, the cases start really just going up, like a classic epidemic curve that you see as an epidemiologist, right? So I, at this point, I'm teaching one of our master's level courses and sort of using this and using all of the research that's coming out as examples in my class, because, right, this is a pandemic or epidemic at this point, soon to be a pandemic that's unfolding before our eyes. We have our first documented case of COVID in Alabama, and then about the middle of the month, the shutdowns begin. Right, so we get sent home, and we will be home for quite a while after that. Around the same time, so my personal sort of interaction with this is that one of my closest friends from childhood, who's a teacher in the New York City public schools, gets COVID. So, she's, if you remember, New York was one of the places hardest hit early in the pandemic. And, she teaches fourth grade, she gets every virus that comes through, and she gets COVID. So, like a lot of people involved in public health and medicine more broadly, I'm trying to think about, how can I use my skills to try and make things better? What can I do to try and contribute to this really, emergency situation? So one of the things that I get involved with is called COVID Core, right? So I skipped one of my things. So in March of 2020, the Enterprise Protocol begins, right? So the Enterprise Protocol is a UAB initiative to really consolidate research on COVID-19. So one of the concerns is a lot of people want to do research, but we really don't want a lot of extra people in the hospitals, right? So we're short of PPE. We have a lot of, we're expecting that there are going to be some very sick patients who are coming into the hospital. And that, we don't want them overburdened, and we don't want a lot of extra people who don't need to be in the hospital to be wandering around the halls trying to recruit people. So enterprise protocol is set up, and it is really designed to be an efficient recruitment and research platform for all types of investigators across the institution. So enterprise is going through, they're consenting patients in the hospital as well as in other settings, but largely hospitalized patients. Adding on to that, about a month later, we start thinking about, through the Center for Outcomes and Effectiveness Research and Education, which Sudeep mentioned, how do we use sort of big data sources to contribute to these efforts, right? So thinking about using EHR data, thinking about using public health data, and so thinking of this as sort of an adjunct to the enterprise protocol. So not just people who are like actively recruited, but using some of our administrative and public health data sources as well. Meanwhile, my friend is still sick, right? So this is weeks later. In May 2020, along with a lot of other people, I don't want to say that I'm the only person who's thinking about this, but I start thinking about, like, what are really the long-term consequences of COVID infection? So my background, I am a cardiovascular epidemiologist by training, but over the last, I'd say 5 to 7 years, I've gotten more involved in studying HIV and the long-term effects of HIV infection. So really thinking about, what are the long-term effects of these COVID infections, thinking through like how infection essentially as a chronic disease. The other piece of this is that, I needed some comfort reading, right? Like a lot of people. So I went on an Agatha Christie kick. And so the early Agatha Christie novels talk a lot about actually people who had influenza in the 1918 pandemic. And there are just like sort of in passing characters who are mentioned, oh, that person had influenza and they were never the same again, right? So it's sort of this recognition that these pandemics do have long-term health consequences. Granted, Agatha Christie is not like medical sociology, but it was just really interesting and struck me at the time. So meanwhile, my friend is still sick, right? So my first attempts to design a study to evaluate recovery from COVID-19. So start working on thinking through, can we get surveys to the enterprise participants? Can we design a bigger study? Like, what are we going to need in order to set up long-term follow-up for people with COVID? And so working with the COVID core, we set up a group of investigators to develop some surveys and patient-reported outcomes to study recovery from COVID-19. Now, a lot of people were doing similar things at the same time. This has led to a lot of different questionnaires that have been used in a lot of different studies of variable sort of quality and reliability. So it took a while. Everyone's sort of running around doing the best they can. So I'm still, summer of 2020, I'm still trying to figure out how to get to surveys to UAB COVID patients. I will say, right, so anybody who has access to COVID patients at this stage is incredibly busy, incredibly stressed. And so, trying to figure out how do we do this, how do we work with enterprise without overburdening the clinicians who are like really doing just heroic work in the medical system. And my friend is slowly getting better. So then I met with a bunch of people, talked to a bunch of people. Finally, in fall of 2020, I get introduced to Nathan Erdman, who is an associate professor in infectious diseases. And his area of expertise, so he is a physician scientist, his area of expertise is the long-term immunologic effects of HIV. And so really thinking through, so he's more of a bench scientist by training, but thinking through sort of how do we do clinical research? I think, hopefully he thinks the same. I got really lucky getting introduced to him because there are a lot of people who, you might work with sort of okay, and some people who it's a little more challenging. The two, I think I text him more than I text anyone in my family. And so we've been sort of working together fairly intensively since then. And luckily we got along because I had been working with him for probably about 6 months before we were ever in the same room. So we start working on ways to get the surveys to the UAB enterprise participants, which we do. And there starts to be, so we start talking about how are we going to get funding to do this long term, because UAB enterprise was funded by the UAB enterprise, but there was a limit to how much the system was going to be able to, or was willing to pay to follow participants. And so we start hearing rumors about a funding announcement that's in the works from NIH to study long COVID. Around November of 2020, UAB establishes a multidisciplinary long COVID clinic, right? So at this point, it's very clear that there are a lot of people who are not recovering fully. Around the same time, just before Thanksgiving of 2020, I get COVID and then long COVID, right? Which was really interesting in retrospect. So, I was quite careful. I hadn't left my house. I'm not sure how I got COVID. And at that point, UAB infectious disease was following people pretty closely. So I was getting phone calls for people with infectious disease. I work with the CFARs and, have this training program that I helped to lead. So the person assigned to my case was a physician scientist who had just finished the training program. So it's, very interesting to get, calls from Dr. Gravitt, who it's like, and then he's like, hi, Dr. Levitan. And, which is both kind of awkward and also helpful, right? Because I have dogs. I was like, okay, like I'm not supposed to leave my house, but should I really have someone come in and walk my dogs if I can do it myself? And he's like, no, like, you should, if you can, put on a mask and like try and stay away from people. But yeah, walk your dogs rather than have somebody come into your home and be exposed. And then finally in February, we get the funding announcement that we've been waiting for, right? So we've been sort of just waiting and waiting, trying to get the surveys up and running, but necessarily small scale because we have a really limited budget. So this is the funding announcement: post-acute sequelae of SARS-CoV-2 infection initiative, SARS-CoV-2 recovery cohort studies. One of the things to note is this does not say long COVID. NIH, so long COVID is something that has sort of like naturally emerged from patient groups, from, just people talking. NIH decided that was not an appropriate term, and so they use PASC, right? So post-acute sequelae of SARS-CoV-2 infection. And what they put out a request for is clinical recovery cohort studies, so prospective cohorts, including both adult and pediatric cohorts, autopsy-based studies, EHR and other real-world database studies, so essentially administrative data, a clinical science core, a data resource core, and then a biorepository. So they asked for these giant proposals. We had 3 weeks to do them. This was a very interesting, I think, both political and scientific process. So there was a meeting, which I was not involved with, that was a lot of the bigwigs at UAB that decided who at UAB was going to be allowed to go forward to lead this proposal. So for, Jeannie Marazzo was selected, makes sense. She was the head of infectious diseases, with Nathan Erdman and I as MPIs. It's because we've been sort of trying to set this up prior to this funding announcement. I will say Jeannie is fantastic. She said to us, this is a political decision. She was very upfront with it, and she was like, I'll do what I need to do to help you, but you're in charge. So that's essentially how we wound up with this. We had about 3 weeks to put this together. So we pulled together a huge team here, as well as at University of South Alabama, and then LSU Health Sciences Center. And the funding announcement said we had to be ready to start within 4 weeks, and that we would find out sometime in April, so to start in May. So we start building a study staff. We start hiring. We get a research clinic set up with the help of the UAB Medicine. in anticipation of NIH funding, thinking that we're a shoo-in, right? Because one of the things that they were looking for was diversity. So in terms of geographic region, as well as in terms of race and ethnicity. So we thought we were a shoo-in because, you know, we're a deep South, that UAB and, you know, the researchers here really have expertise in terms of recruiting and retaining diverse participants. So, you know, that was put forth. So we thought we were pretty likely to get this if it goes forward. And then we wait. So now we're spending money that we don't really have for clinic staff and space, and it's getting really anxiety producing. So finally in June, and we get told, okay, there's going to be a phase 1 of Recover. And phase 1 of Recover, like, yes, you did all this data, like all this planning, all these budgets, all this stuff. We're going to start from scratch. And so now we're going to spend 6 weeks intensively designing this study. And so they invited us to, you know, Jeannie, Nathan, and I to work on this. And there are hundreds of investigators who have been invited to work on different parts of this. There are also patient advocates who were involved from the beginning, from the study, you know, from the study design. There are committees addressing social determinants of health, things about study design, different sorts of physiologic systems, omics, like everything you can think of, there's a committee. These committees are intended to use like a Delphi method, a consensus building process. I will tell you that did not happen. Getting this many people on a call and trying to get any sort of consensus within this time frame, yeah, didn't really happen. So we were meeting 3 to 4 times per week, about 2 hours a day. So each of us on different committees. And then in July, we're told, okay, now we have a sort of outline for a protocol, and well, here's your budget, here's how many people you can recruit. Do you want to apply to do this again? So we have about 10 days to put in our second application, which we do, and we do get funded. Also keep in mind, right, so that's my perspective, what's happening with the pandemic. So thank you, Dean Irwin. I was able to go back through your emails and pull these, pull this graph. Okay, so we are, I know I'm not supposed to do it, I'll go back. Right, so we're applying initially here. We're developing the protocol here, and then we have the Delta wave that comes after. So this has some implications for our study design that I'll point out in a second. So October 2022, Cleveland and UT San Antonio recruit the first adult cohort participants for Recover. We're still trying to get our contracting through.
That's typical.
Yep. Meanwhile, December, right? So then we get the Omicron wave in December and January of 21-22. And also, so we get the contracting through, then the coordinating center at NYU didn't realize that we were a university, and so we got delayed by a month because they kept ignoring our IRB for their single IRB. So anyway, we started a month later than all the other sites. Finally got that figured out. And we finally got them to stop sending things to University of Alabama. So we finally recruit our first participants in February of 2022. So it's been really sort of a wild ride. This is the first time I've been involved in a prospective cohort study from the very beginning. And I think it's always rocky, but trying to set these up in the middle of a huge worldwide emergency has been challenging in a lot of different ways. So now I'm going to talk a little bit about the study design. So this is the Recover logo, and there are a bunch of different components of Recover. right? So what I've mostly been talking to you about is the adult prospective cohort, because that's the piece that I've been most involved with. There's also a pediatric prospective cohort. The pediatric, interestingly, overlaps in age range. So the adult cohort is 18 plus. The pediatric cohort goes up to age 26. In addition, there are pregnancy dyads, right? So the parent-baby dyads enrolled in both the adult and pediatric cohort. There are also these EHR-based cohorts. So these are, NC3 is one, so, and UAB is part of that. So our medical record data goes to one of these EHR components. There's a pediatric EHR component. There are also clinical trials, and I left off the autopsy studies here. So apologies to the autopsy investigators. And so what I'm going to talk about next is really focusing on that adult cohort, because that's the piece that I'm really involved with. So our recover adult cohort objectives. So the purpose of this study is to characterize the spectrum of PASC symptoms and define the incidence, prevalence, and underlying mechanism of PASC in the adult across multiple sites in the US. Specific aims to characterize incidence and prevalence of PASC, including clinical and biological features, severity, distinct phenotypes following COVID-19 infection. Characterize the clinical course and recovery of sequelae over time and determine associated risk factors among COVID-19 infected individuals and compare them with uninfected individuals. Define the pathophysiology and mechanism of post-acute sequelae, including direct and indirect causal effects and potential modifiers. And then we hypothesize the study will elucidate risk factors that contribute to PASC progression. So this, in other words, the study is meant to answer all the possible questions, right? So if you take a class with me, one of the things that I usually teach is about creating an answerable question. And so this would not do well, right? So this is, which makes sense, right? You're going to ask broad questions for a very big research initiative, but it also reflects the fact that this study is really designed to try and do everything, which leads to some challenges in terms of having it actually run and being able to answer with a lot of precision very specific questions. So with this Recover Adult study, there are 14 hub sites, including UAB. There are 85 total recruiting sites. So, for example, LSU, University Medical Center in New Orleans wound up being one of our subsites, as well as University of South Alabama. There are about 14,000 adult participants. The intention was to have 15% uninfected individuals to serve as sort of a comparator group. Now, remember, that plan was designed pre-Delta wave. By the time we start recruiting in February of 2022, we've had the Delta wave and we've had the Omicron wave. So finding people who've never been infected is a real challenge, right? And even people, about a third of people who come to us and say, oh yeah, I'll be in your study and I've never been infected, about a third of them have antibodies to COVID, right? So, and not the vaccine antibodies. So we're recruiting people in a bunch of different groups. So people who have their acute primary infection. So we're trying to recruit people essentially in a window of 10 to 30 days, or we were trying to recruitment's now over, but 10 to 30 days post-infection, right? So no longer hopefully infectious, but still they were like actively recovering. We are recruiting people essentially in that 10 to 30 days. They added eventually reinfections. We are recruiting people who are post-acute, and I've never understood what the difference between the prospective and retrospective post-acute is, but those are the different groups that we're recruiting. And then in order to try and look at the trajectory of recovery, every person in the study is assigned an index date. So for people who are infected, it's their infection date. For people who are uninfected, so then what they decided to do was use the test negative date, right? So sometimes we're recruiting people within 10 to 30 days of testing negative, and sometimes we're recruiting people who are farther out but tested before that. Again, remember this was designed pre-Delta wave. So this, and people were, and also pre-home tests, right? So this is that study design, you know, I think that circumstance led to this sort of idea of the study design. So this might look familiar to you if this isn't your first year at UAB, because this was on the monitors downstairs for several months. So it's very easy to recruit people who have long COVID to participate in the study. It is much harder to recruit people who are either just recovering and maybe have used up all of their sick leave, or people who've never had COVID. So this is the study calendar. We have baseline visits, and then we have visits at 3 months, 6 months, 9 months, 12 months, 15, 18, 21, 24, 27, 30, 33, 36, 39, 42, 45, and 48 months. And these are not after enrollment. This is after the index dates. This is after hospital, or after the infection, or after the test negative date, right? So this is a complicated study design. So some people are starting essentially with that 3-month visit if you are, were recruited shortly after you got COVID. And some people are starting, say, at visit 18 or 18 months. There is, enrollment consent, all the sort of usual stuff. There is assessment of comorbidities, what kinds of treatment you got while you were acutely ill, current medications, demographics, symptoms, vaccination, social determinants of health, alcohol and tobacco, disability, pregnancy, sort of basic office visit. So the questionnaires happen more frequently than the office visits. A collection of biospecimens. So this is blood, urine, stool, nasal swabs. There was an ancillary study to collect tears. So there's a wide variety of different biospecimens that are being collected. We're doing clinical lab tests, right? So lab tests that can be done through UAB hospital labs, as well as sending biospecimens to a repository. And then we have these tier 1 and tier 2 and tier 3 tests, which we'll talk about a little bit more in a minute. So the symptom survey, right? So all these surveys take somewhere between, I'd say, half an hour and 2 hours, depending on how quickly people are reading and answering, as well as these surveys pop out a bunch of more questions depending on how you answer. So symptom survey starts with standard questions about health-related quality of life, physical, mental, and social function. So, right, so as an epidemiologist, these are questions that are going to look super familiar from NHANES, from the BRFSS and other sort of standard data sources that we use all the time. Then there's questions around about 30 different potential long COVID symptoms, right? So timing, and it's not just, do you have this symptom? Yes, no, it's questions about, did you have the symptom in the year before your COVID infection or your random index date if you tested negative? So I think those are hard questions to answer. Did you have it sort of in the short term? Did you have it in the long term? And do you have it now? There is a question about, for people who had symptoms before their COVID infection, there's a question about whether they've gotten worse. And then there's additional questions about bother, right? So how much does the symptom bother you? How much does it interfere with your daily life? And then if you say, yes, I've had GI symptoms, it's going to pop up a survey that asks you a whole bunch more questions about severity and specificity of these GI symptoms. All right, so this is why the questionnaire length is highly, highly variable depending on the sort of symptom burden. Okay, then we have these tier 2 and tier 3 tests. So I think another interesting thing about the team that's working on this is there's me and one other person who's sort of a card-carrying epidemiologist on this study. And so I don't think an epidemiologist with that as their primary training would design a study like this, because we now have these tier 2 and tier 3 tests which are, so it works kind of like clinical care, right? Or where a combination of symptoms and laboratory test results trigger additional tests. And these are not additional tests that, for the most part, our clinic staff, our research staff are doing. We have to then get people into the UAB clinical system. So we get some people who are, being sent for these additional tests through because of symptoms and because of other laboratory findings. And then we also get a random subset of people who don't have these symptoms or lab results who get the non-invasive tests. There's some highly invasive tests that are limited just to people who essentially have the clinical indication. So here's a list of all the tier 2 tests. I don't expect you to read them all, but just to point out that this is everything from a 6-minute walk test, which actually we do in our research clinic. That's something we can have our research staff do, to a full ENT exam, right? So we have to get somebody in with the ear, nose, and throat specialist, and we have to do it within about, depending, like 9 to 12 weeks of their office visit with us. So if you have had to have any sort of specialized testing through UAB health system or any other big academic medical center, you know that a lot of times you have to wait longer than a couple of weeks, right? And we have to coordinate this with people who are, have lives, right? So they're not just our research participants. So we have to have people, potentially take off work for these, or, get rides, that sort of thing. And then we've got our tier 3 tests, right? So this includes cardiac MRI, includes tilt table testing, includes things that actually we can't do at UAB. So they have this endopat testing, which is a measure of vascular function. I have talked to probably 30 people at UAB to see if anybody has an endopat machine, and nobody seems to have one, right? So, and the Recover study was not going to buy us one. So anyway, there are certain things that we don't do at our site just because we can't. So what does a study visit look like for a participant? So this is a picture of where our research clinic currently is, CH20 building in 5 Points. We put this on our letter because when we were initially in a different location, when we moved, I put our address into Google Maps for our new clinic, and it showed a side door that said "Do not enter, stop radiation." So we figured that was going to discourage a lot of people. So we made sure we had a map and a photo. People have to come in the morning fasting. Now, we pushed really hard not to have this be the case. We pushed hard to have non-fasting visits to be able to do this nights and weekends, and as well as home visits. However, the decision was made that the physiologic measures would be more accurate and more interesting if there were fasting visits, which I don't disagree with. But I think one of the challenges with a big study like this is, they have these priorities to have a diverse participant population. But if you're saying you can only come in Monday through Friday in the morning, and you have to be fasting, and you have to be within, a couple weeks of COVID infection where you just took off work, we did somewhat limit sort of who could participate. It's better for us than for people on the West Coast, because they also have to be able to hit the FedEx overnight shipping to get the biospecimens to the lab. So they actually have an even more compressed window in terms of when they can see their participants. So what does the study visit look like for the participant? So the stars are things that don't happen every visit. So, you do the study consent, you talk to the coordinator, potentially talk to one of the investigators about the study. If you decide to do it, you'll do a basic physical exam, a blood draw, right? So we have some samples that are going to the clinical lab, some that are going to the repository. People can opt out of the repository portion, which is, from a workflow perspective, has caused a lot of problems study-wide, because if you get in the habit of just drawing these 2 sets of labs, there were a lot of people well, not a lot, but there were more than a handful of people who got samples sent to the repository who had actually opted out. We've got urine collection, again, with those sort of two sources for where samples are going. People are sent home with a stool kit. Very few people return them. But and then you've got this whole set of surveys, additional tier tests that, so these like things like the 6-minute walk, like the rehabilitation exam, which Bjorn helped train our staff in. Some of those are happening during these visits. And then we're also calling back participants for the more involved tests that we can't do, or that where we're not getting the results right away. So, that it's triggering based on these clinical labs. And so then people are coming back we try and combine them. So like people are having multiple tests within a single visit, but people can get called back for 10 different tests, and they might not all be scheduled on the same day. So what does this look like from an epidemiologist perspective? We have 8,262 data fields in our Recover REDCap database, which is just enormous. We have about 14,000 participants. There are millions of biospecimens in the repository, right? Because we're collecting longitudinally, and then also that everything's are getting divided up and aliquoted. We're supposed to be getting data more to come, linkage with electronic health records, linkage with Fitbit and other activity trackers. There's a mobile app that participants can opt into where they're reporting their symptoms. There is a proposal to do whole genome sequencing on the entire cohort, as well as other omics in some subsets. So, that's another, 20 million data fields, at least, as well as hypothesis-driven biomarker testing, right? So once we start using the biospecimens that are in this repository. So this is a really big, really complicated, really unwieldy study, but with a huge amount of data and a really big study population. So this is data, like I said, data collection is still ongoing, right? So I'm going to talk a little bit now about the one of the first papers inside works from the adult cohort that's come out. So as background, right, so the Department of Health and Human Services has this long COVID case definition. And they say long COVID is broadly defined as signs, symptoms, and conditions that continue or develop after initial COVID-19 or SARS-CoV-2 infection, right? So the rest of this is sort of adding a little bit of granularity, but not a whole lot of specificity, right? So this is a fine case definition for like individual sort of clinic encounters. It is not a very workable definition for the research purposes, and one of the things that seems to be emerging and emerged pretty quickly as long COVID research was developing was that this is probably not all one syndrome, right? That there's probably multiple things that are going on with different mechanisms and probably different treatments. So this paper came out a couple months ago, and the intent was to develop a definition of post-acute sequelae of SARS-CoV-2 infection. It included Recover adult participants who had a visit that was at least 6 months after their infection date or test negative date. It considered symptoms with a reported frequency of greater than 2.5%. So this is definitely missing some more rare sorts of manifestations of long COVID. And so what they did, and so this has been sort of a point of contention about this paper, was we used lasso to sort of, which is a variable selection technique, to figure out what symptoms most differentiate between people who had an infection and people who did not have an infection. So that's not really a definition, right? That is a way of saying, okay, here's a set of symptoms that are going to tell you if somebody that are selected to tell you if somebody was in that population that had a history of COVID and COVID disease and people who did not have a history of COVID disease. From that, there's a score that tells you, okay, PASC positive versus PASC indeterminate. So this is sort of the PASC indeterminate is sort of the hedge portion of this to say, okay, we're not saying that people who don't sort of test or aren't sort of positive based on our scoring system. We're not saying they don't have PASC. We're saying it's sort of unclear if they have PASC or not. And then the piece that is that I find most interesting is among those who sort of are in that, yes, we think this person has PASC, we went and identified clusters of symptoms, right, to try and get at that idea of these sort of subsets of long COVID. So these are the model selected symptoms that most differentiate between people with a history of COVID and people without a history of COVID. So loss of smell and taste is number one, right? And so this is very specific to COVID. Post-exertional malaise is probably more debilitating, but is a symptom that happens with other types of conditions as well, right? So that's sort of why it ranks a little bit lower. Chronic cough, brain fog, thirst, palpitations, chest pain, fatigue, change in sexual desire capacity, dizziness, GI symptoms, and abnormal movements, right? So these are the symptoms that were selected using this automated process. But these symptoms don't travel alone, right? So this table, which is buried way in the, E-table 7 of the paper, shows you all the things that are correlated with those main symptoms, right? So a loss of smell and taste goes along with fever, sweats, and chills, which doesn't show up in our model at all. It wasn't selected, and it does, and it also goes along with headache that wasn't selected. Post-exertional malaise is sort of traveling along with weakness and shortness of breath, right? So you can sort of see going through each of these symptoms. And then based on sort of balancing how many people without a history of COVID are going to test positive for PASC, which is sort of a weird idea. So they said, okay, we're going to cap that at like, I think 5%. It wound up being right around 4%, right? So they picked, it's essentially like picking the 0.05 for your statistical significance threshold. They just sort of said, okay, this is the number of false positives that we're willing to accept. I said, okay, a score of 12 is sort of how we're gonna say this person has long COVID. You can see so that's what this graph is, where you see it's sort of what the different cutoff scores are and what the proportion of people who would be classified as PASC who do not have a history of COVID, right? So that's what that panel A of the graph is. Panel B shows you the symptom frequency among people who tested positive for PASC using this approach. You can see things like post-exertional malaise and fatigue are very common. Abnormal movements are less common, but again, they threw out any symptoms that were not common at all. And then we have this idea of sort of what are the symptom clusters, right? So with the idea that the symptom clusters are going to be representing sort of distinct phenotypes within long COVID. And so here are the whole list of symptoms, which I'm sure you can't see. So I've just sort of pulled out the characteristic symptoms. So there's 4 different clusters of long COVID that were identified in this study. The first one is really characterized by loss of smell and taste with sort of scattered symptoms in other organ systems. Cluster 2 is characterized by very high proportion of fatigue and post-exertional malaise, so greater than 80%, and again scattered symptoms in other. Cluster 3 is fatigue, post-exertional malaise, and brain fog. And then cluster 4 is sort of the most symptomatic and includes fatigue, post-exertional malaise, palpitations, GI symptoms, dizziness, and brain fog. So some conclusions and challenges with this paper. So what we've done here is identified symptoms that best differentiated people with and without a history of long COVID. There was within the author group a tremendous amount of discussion and angst about what the title of this paper would be, because it is titled A Definition of Long COVID or of PASC. And I really don't think we've created a better case definition. That's sort of what was the intent, but I don't think we quite got there. I do think that the symptom clusters, this is why for me the symptom clusters is a far more meaningful result here, and really thinking through that these are potentially different syndromes and require different treatments. It didn't include findings, right? So this was entirely based on the symptom survey. We don't include clinical signs, diagnoses, or biomarkers. That sort of refining this approach using all these other data sources is in the works now, but that was none of those characteristics were included in this particular study. So it's, I think the response to the study has been kind of challenging. I have about 400 emails in my inbox from patient advocates saying that the study should be withdrawn. And because with concerns that this is going to be used as by insurance companies and that people are going to lose access to care, which I understand, though I'm not sure that those concerns meet the bar for actually withdrawing a paper, which is a huge thing. So where do we go from here? So we are funded for follow-up for another 2 years. It's unclear what will happen after those 2 years. The whole study consortium is undergoing a change in the leadership structure. Very early, initially NIH and the coordinating center at NYU had a lot of control over most of the decisions that were made about sort of the conduct of the study, which is not common for most NIH studies, right? So most NIH studies, and Suzanne's shaking her head, have a lot more sort of the investigators, the people on the ground who are collecting the data have a lot more input. There were a huge number of committees and task forces with unclear authority and sort of overlapping scope. So those are mostly gone now. So which I think is a good thing, but also, it's hard to tell somebody, oh, you've spent hours and hours and hours on this and now goodbye. So, there's been a lot of, I think people have felt like their contributions weren't recognized. We are starting to enroll participants in clinical trials. That's been one of the slowest pieces to get up off the ground, but hopefully we will enroll. So there's, I think, 2 clinical trials that have enrolled participants. We're going to start enrolling at UAB hopefully in the next week or 2. So the intent of Recover is that the data in the biorepository will be open to the scientific community. We have a lot of work as epidemiologists and biostatisticians to figure out how to validly analyze these data. So we have longitudinal data collection on these symptoms. We've, over the course of the study, already changed the way the data is collected in a couple of key ways. We've got repeated infections. We have kind of spotty collection of acute events, right? So if people are hospitalized, that makes things a little hard to sort of think through, like is it the hospitalization that affects your symptoms or something else? We have lots and lots of missing data. A lot of this is by design, right? So we will have severity scores, but only among people who report having that symptom. And then there's the tier testing where we're selecting people for additional studies. I have never been involved in anything that had that much sort of skip pattern in terms of the way the surveys are. So I'm not exactly sure what you do with this. We also have missing data because of, frankly, the complexity of the protocol, right? So getting people for a cardiac MRI within the study window is not an easy task, right? And it's not just the cardiac MRI. We have, 20 different tests. And so we've had to try and make contact with, 20 different groups across campus who see patients clinically and, sometimes people are excited and interested and want to help us. And sometimes people say, I have a wait list that's like 6 months long for clinical testing. Like, I'm not going to bump my clinical patients so that you can get your research study done. So we have some of both. And then we also, like any study, have lots to follow up. This is a particularly high burden study. So we are, really trying to make sure that participants do stay engaged. And then the intent is that we'll integrate all these different Recover components, but it's not exactly clear how you do that. And so I think that's also something that we're working on the methods now. This study had very high expectations from the get-go. It's also very expensive, in part because of trying to do things really fast and at all these different sites. This is a major concern, right? A major health concern. So we need rapid production of results. And like I said, this is the paper I showed you is the first results paper that's come out from the adult cohort. So there's a lot of frustration with that. There's also a lot of people involved, many investigators and patient advocates, hundreds. And so trying to get that many people going in one direction is a challenge. So I'll end with some acknowledgements. First, the funding, and then in particular, Nathan Ergman and Jeannie Barazzo, who I've worked with on this project over the last couple of years, the CH20 research team, who managed to get all of our participants in and out and with very few complaints, which is really a wonderful thing. All the investigators and collaborators at UAB and other institutions, and most of all, and most importantly, all the Recover study participants.